Welcome to the Practicing Clinicians Exchange podcast, highlights from the American College of Rheumatology 2021 Annual Conference, Part 1. This program is being presented in partnership with the Society of Physician Assistants in Rheumatology. I'm your host, Dr. Vibeke Strand. I'm an adjunct clinical professor in the Division of Immunology and Rheumatology at Stanford University, and also a biopharmaceutical consultant. Today, we'll be talking about some exciting new information that was just presented at the ACR Convergence annual meeting. This program is provided by Practicing Clinicians Exchange for 0.25 ANCC contact hours and 0.25 AAPA credits. Supported by an educational grant from Amgen, and to receive credit for this program, please go to pce.is/ACR. Our learning objectives are that at the conclusion of this podcast, you'll be able to, 1, identify recent practice-changing data across major rheumatologic conditions, and 2, formulate strategies for the management and monitoring of patients with rheumatologic conditions based on the most current efficacy and safety evidence. Let's start with abstract number 0455 by Jürgen Reck and colleagues. And this was what's called the ARIAA study, abatacept reverses subclinical arthritis in patients with high risk to develop RA. So these were patients who were randomized to receive placebo or abatacept for 6 months and were thereafter observed for another 12 months without treatment. These patients had presented with arthralgias for 6 months, but did not have joint swelling. And they were also assessed by inflammation by the MRI in the dominant hand. And they had MRIs at baseline, 6, 12, and 18 months. The endpoint was improvement in at least one MRI inflammation, e.g. changes from baseline in either synovitis or tenosynovitis or osteitis. And this is based on the well-known RAMRIS score for MRI development in rheumatoid arthritis, which has predicted progression to swollen joint counts and frank rheumatoid arthritis. So there were 100 patients randomized 50-50, and essentially the MRI was evaluable in 45 of the abatacept patients and 41 of the placebo. And there were very few discontinuations early, only 14% with abatacept, but 43% or 21 patients with placebo, and that was statistically significant. So the improvement in the MRI score by any one of the parameters I mentioned to you was present in 61% of the abatacept patients and only 31% in the placebo patients. And those that already developed arthritis in that short period of time were 4 with abatacept, 8%, and 35% with placebo, again, statistically significant. It was very well tolerated. And the point being is that there's been several other early studies of patients who were predicted to develop rheumatoid arthritis with rituximab and other agents, and they've not been successful. So this is really the first to show that you could possibly treatment prevent the onset of rheumatoid arthritis in high-risk patients. The next abstract is 0957 by Han et al. Vitamin D and marine N3 fatty acids for prevention of autoimmune disease across the US. This was called the VITAL, VITAL study. And this study ran from 2011 to 2017 and included some 5,000 patients out of 25,871 that were randomized that were African American. So basically, it was a test of daily vitamin D supplementation and or inclusion of daily oral fatty acid supplementation. As I said, 25,871 patients, about roughly 50-50 for men and women, all over the age of 50. And the dose of vitamin D was 2,000 international units a day, and the dose of fatty acids was 1 gram a day. So essentially, we had patients who got vitamin D and fatty acids, patients who got vitamin D only versus placebo, patients who received fatty acids versus placebo, and patients who received none. The primary endpoint was cancer and cardiovascular disease, but this study was a sub-analysis for autoimmune disease onset. And they did baseline questionnaires and so on and so forth. And essentially, they were followed for 5.3 years, a range of 3.8 to 6.1. So what was very interesting, there was a less incidence of autoimmune disease onset in those patients who received vitamin D. Hazard ratio was decreased to 0.78, and this was statistically significant. For those who received fatty acids, there was a numerical improvement, but not statistically significant. And the vitamin D plus fatty acids was not better than vitamin D alone. And there were no statistical interactions between both. So this is a really interesting study that we already know the safety of both supplements was quite good, and it pertains to older adults. But we wonder whether, in fact, if this type of therapy was started earlier in younger patients, whether it would have had even more interesting results. So the next two I wanted to summarize was from an FDA session. And essentially, they went over very quickly the recently approved products and the safety. And I'm going to do that and then lead into 0958, which is about the oral surveillance study with tofacitinib. So the recently approved products within about the last year include new molecular entities, and that means voclosporin for lupus nephritis, which was approved in January of 2021, and anifrolumab for lupus, a type 1 interferon receptor inhibitor, and that was approved in July. And then finally, avacopan for ANCA-associated vasculitis, which was approved in October. The new indications that were approved included belimumab, now for lupus nephritis as well as lupus, and that was in December of 2020. Tocilizumab for ILD, interstitial lung disease, and systemic sclerosis, and that was in March of 2021 for a sub-Q dose of 162 milligrams weekly. Rilonacept for recurrent pericarditis in March of 2021, and then immune globulin intravenous 10% for dermatomyositis in July of 2021. So these are exciting, but I'm not going to go through the various details with each of the products, except to say that it's really an exciting year to have this many approvals for rheumatology. I think what's more important was the safety that they outlined, and the FDA Division of Rheumatology and Transplant Medicine spent most of their time talking about the JAK inhibitors and their safety in inflammatory conditions concerning MACEs, major cardiovascular events, malignancies, thrombosis, and mortality. And then they discussed the revisions to the warnings for these JAK inhibitors, meaning tofacitinib, baricitinib, and upadacitinib, which are currently being negotiated with each of the three sponsors. And finally, the revisions to the indications that they've also requested. Moving on from that brief overview, I'm going to talk about the oral surveillance study, which is a phase 3b/4 trial with tofacitinib versus either of two TNF inhibitors, adalimumab or etanercept, that was mandated by FDA as a safety study. Essentially, patients were randomized. It's an open label study, 3 arms, tofacitinib 5 milligrams BID, 1,455 patients, tofacitinib 10 milligrams BID, 1,456 patients, and either of the two TNF inhibitors, 1,451 patients. Etanercept was used ex-US and adalimumab within the US. These were patients who were more than or equal to 50 years of age and had more than one cardiovascular risk factor. And the co-primaries were the incidence of MACEs, And MACEs are defined as cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke, or malignancies, which included all malignancies except non-melanoma skin cancers. The trial was designed to exclude a pre-specified risk margin of 1.8 for the hazard ratio of combined tofacitinib regimens versus combined TNF regimen. This was for each co-primary, meaning one for MACE and one for malignancy. Now, the sample size and the defined hazard ratio upper limit, a 95% confidence interval of 1.8, was based on the safety study from more than 5 years ago of tocilizumab versus etanercept, and might not have been an adequate sample size based on the fact that we already know from our progressive trials in rheumatoid arthritis that our patients are progressively becoming healthier with less comorbidities and longer lifespans with rheumatoid arthritis. So essentially, the median onset study follow-up was 4 years. Now, the results were actually summarized in primary data in the abstract 0831, where they talked about the incidence of cancers, also thromboembolic events or VTEs, and infections. And then these were also summarized in other specific abstracts of 1940, 1941, and 1684. So what we remember is at the end of 2019, the Data Safety Monitoring Board had already said that there was a signal identified for tofacitinib, particularly the 10 milligram BID dose for VTEs or thromboembolic events. And that dose was then discontinued and patients were put back onto the 5 milligram BID dose. And the box warning for tofacitinib was updated, as was those for baricitinib, which already had a warning, and one was added for upadacitinib. In January of 2021, the safety analyses were completed, and Pfizer had a press release that indicated an increased risk of serious heart-related problems and cancer with tofacitinib compared with both TNF inhibitors. Finally, in September, FDA announced that they required warnings to be revised, and they asked each of the JAK inhibitor sponsors to revise the warnings and indicate that there were more risks and that the indications should be limited so that patients had to fail a TNF inhibitor prior to receiving a JAK inhibitor for rheumatoid arthritis. What we do know is that essentially the analyses of the patients who've been switched to 5 milligrams BID were still analyzed as if they had received 10 milligrams the entire time. And what we know from 0958, Charles Schumann et al., which was the poster that described the risk factors in patients more than 50 years old with RA and additional cardiovascular risk factors from this study, was that essentially data indicated that tofacitinib, both doses, was not non-inferior to TNF inhibitors in terms of the incidence of MACEs and malignancies. The combined doses had a hazard ratio of 1.24, and that exceeded the upper limits of 1.8 for the 95% confidence interval. And similarly for cancers, it was 1.47, and this also exceeded that confidence level of 1.8. Now, these are not statistically significantly increased over the TNFs. It's simply that they are not non-inferior to the TNFs for the hazard ratio. And the higher incidence ratios for both North American patients versus the rest of the world were noted. And in a post hoc analysis, these were the patients from the US who were greater than or equal to 65 years of age and had ever smoked. And predominantly, they suffered myocardial infarctions and lung cancer. Interestingly, I just said to you that although this was not inferior statistically, but not statistically increased, the number needed to harm were quite large. In other words, the number needed to be treated in order to have such a harmful outcome. For the MACEs, it was 567 for 10 milligrams BID, and for 5 milligrams BID, it was 319 patients. And for malignancies, it was 276 patients and 275 patients, respectively. Now, what I understand about these data is predominantly they're based on the baseline risk factors. However, I have no plausible mechanism to explain why the occurrence of either VTEs, MACEs, or cancers would be higher with tofacitinib than the TNF inhibitors. And we are all still wondering how this result actually occurred, but may be best explained by the fact that the studies were essentially not large enough in size. They were based on an older safety study that was adequate, but this may indicate that our patients are getting progressively healthier with less comorbidities. So the labels will be revised to state that patients need to fail a TNF inhibitor prior to a JAK inhibitor for treatment of RA, and presumably also PSA and SPA when that is finally approved. But we already know that that's general practice anyway. And just to remind you, we do know that we now have about 23 years with the TNFs, and we're only looking at as much as 9 years with tofacitinib and much less with the other JAK inhibitors. So we don't really know if this is truly a drug effect, treatment effect, or where this reflects the underlying comorbidities of our patients. But it means you should be careful in selecting in whom you would recommend use of a JAK inhibitor. So I hope that these summaries have helped with understanding some of the important data that I think arose out of the ACR meeting. And thanks for listening to this podcast. I really appreciate it. And as a reminder, don't forget to claim your CME, CE credits at pce.is/ACR.